I think I have a fun topic to talk to you about. Lots of women here. Many of us have been pregnant once in a while here. So not too many, but New York City, it's pretty common, especially in my practice. Anyhow, this is my disclosure. As you can see, I serve as a consultant. I cannot be on a bureau speakers because Mount Sinai really monitor what we speak for, which is good. And I received grant from Biogen and Novartis, and I will discuss off-label use of IVIG. It's not approved, but I will discuss it. Okay, so let's move on. This is my program objective, as you can see. We'll talk a little bit about fiction and facts, and then I will share with you the evidence as much as we have today. Pregnant women, by the way, today are not considered vulnerable population in research. It has changed recently. However, you still are concerned about pregnant women, and there are not that many studies. And then I will discuss mainly the association between reproduction, pregnancy, DMT use, breastfeeding, postpartum periods, and multiple sclerosis. So I think really there are many questions that we face in our clinical practice when you take care of women with MS. The majority of our patients are women, as you know, 3-to-1 and perhaps 4-to-1. But definitely we ask, does MS affect pregnancy? Does pregnancy affect the MS? So it's a bidirectional really relationship, but there are many questions that comes up. C-section is very common in the use of patients with MS. I think overall it's probably more common use, but we'll talk about all this. So some fictions versus facts. Many of you are nurses, many of you work with patients with MS. So the first one, pregnancy, I would not read all of them, but pregnancy is contraindicated in MS. Obviously now we have the discussion here today. Women with MS should not contemplate because of the risk of MS, the genetic risk of MS. We know it's a low risk. We have some women that meet in our waiting room and get married together, and they have actually almost 15% chance of their kids to have MS, and it doesn't prevent them from getting married and having children. So I think it's important to remember it is still a low risk. Is childbirth also going to be done to C-section and not vaginal delivery? And what about bonding and epidural in pregnancy? Yes, women with MS can potentially have more issues during pregnancy, are allowed to have steroids during pregnancy. By a show of hands, how many think women that are pregnant are allowed to have steroids during pregnancy? Okay, there are a few hands out there. We'll talk about that. MS may be on DMT during pregnancy and other questions. And babies of women with MS are small for their gestational age, and we'll discuss that as well, the evidence. Here it talks more about birth control pill, IVF medication, very interesting evidence about few medication about IVF. So I will pose the question to the audience again. Women with MS may take any in vitro fertilization medications? Yes, no, true? False? No raising hands, no brave crowd. Tricky question. And relapses never occur during pregnancy. We'll talk about this. Okay, so many questions. I hope I'll give you some answer throughout the talk. Again, overall, if you think about multiple sclerosis as a chronic illness, as an autoimmune disease, overall there's really no major effect of the that MS really affect fertility, the rate of conceiving, fetal viability, pregnancy and delivery. So there is no major effect, although there are some issue related to that. Always remember, Mary Jean mentioned shared decision. Important to discuss what women and their partner and the family. It's a team approach between the whole MS team and the family. So important always to involve and educate. Okay, so as I said, there is no effect of MS on fertility and the rate of conceiving. However, one of the major one of the major symptoms of MS is sexual dysfunction. You can consider it as a side effect. But sexual dysfunction, which is happening in 50 to 90% of people with MS, male and women. So, of course, if you don't perform, you not get pregnant, correct? You won't be fertile. So you need to address sexual dysfunction. And I think as a team, you have to ask the question. I'm sometimes amazed at couples that comes to me, see me, highly Orthodox Jewish couple that opened the discussion. And I feel honored, first of all, that they opened the discussion. But recently, I had, I'll tell you a quick case that really emphasize the importance of communication. We actually have talked about it many times, and I've seen this couple in about 2 or 3 weeks ago, and they come, the patient is a man. The man is the patient with MS for many years on a DMT, doesn't matter which one, and I have put him on Cialis, on a daily Cialis, and send him to a specialist, thought that maybe the specialist will have other ideas, which they have other ideas. They spoke about injection, penile injection, and other things. So I discussed it with the patient. So are you going to do? So he was looking at me and says, look at his wife. They always come together, by the way. And he says, I don't think I'm going to do those penile injections. So I said, why? It sounds very uncomfortable. So I said, well, the satisfaction of your wife is important, and obviously the Cialis is not effective. And he looks at her, he smiled a bit, and it's okay to smile. Sometimes we think we should be really serious when we talk about sexual dysfunction. But he looks at her, so I said to him, if you want to satisfy your wife and have a good married life, you need to try the penile injection. So in the end, he said he will try it, and then I said to them, you have to use humor though. I said, this is all the family counseling I'm doing today, so let's go on to the usual thing. So I think that was, you have to discuss it, but be comfortable with it and use humor. It's okay. I don't know why people think that when you talk about bowel, you can smile, but not about sexual dysfunction. So anyhow, so what's really important to think about sexual dysfunction, about all the primary causes for sexual dysfunction. And if you're doing an MSCN test for the MS certification, it talks about a lot of primary and secondary, and I believe Carrie will talk about it as well. But what's primary for the disease is different than primary reason for sexual dysfunction. So you can see primary here, it's the decreased libido, decreased interest, erectile dysfunction, ejaculation dysfunction, vaginal dryness, numbness, any difficulty achieving orgasm. So it's really have to be primary related to the sexual dysfunction. And then the secondary, it's more of the other causes, like fatigue, for example. It's primary for MS, but it's not primary for sexual dysfunction. So it can get tricky. But then all the social, the tertiary, and quaternary, people even talk about the last one, the fourth, that it's more of the unnecessary things that we do to really treat an illness. So important to look at primary, secondary, tertiary, and quaternary. You really want to think about the symptoms that you're taking and how you can really identify it. Recently, I actually treated a woman. First time I used this medication that FDA approved to decrease the engorgement, vaginal engorgement, and the sensation, hopefully, orgasm. I can't tell you if it's effective or not, but it's called ADDY, A-D-D-Y-I. I had to go through training to prescribe that. If someone is interested, I can email you. But anyhow, because you cannot drink it all alcohol once you take this medication, it causes severe hypertension. So that's important to know. But once you get the certificate, you can prescribe it. So important to think about this. So sexual dysfunction is the main cause sometimes for lower fertility rates in women with MS. As I mentioned, there are many studies that shows that fertility rate in MS is the same as the general population. A recent study that I would like to share with you from 2015, so the recent evidence, showed that women with MS has a significantly lower hormone, and it's called anti-Mullerian hormone, which is very, very important for ovarian function and ovarian reserve. So it's an indicator, and it's separated from the hypothalamus pituitary gonadal ovarian axis. And I'll talk about the axis in a second because you want to think about this feedback loop. However, this hormone is independent of the HPG cycle. So it's not related to that cycle, okay? And definitely important. So it has been seen. It was a small study. There were about 76 in the women with MS, and control were about 60, so less than 100. However, it showed reduction in numbers. The other things that people have seen, that the use of assisted reproductive technology, ART, is used more in patients with MS. And why? There are a number of reasons why it's used. Number one, the diagnosis of MS may delay thinking about getting pregnant. It's a fact. You're being diagnosed, you're young, you have to think about this. And maybe if you're not married, the marriage, and then the pregnancy, if you're interested in having children. We talked already about the sexual dysfunction, and then it's very interesting that there is increased endocrinological and hormonal disease disorders. Mary Jean just mentioned the thyroid dysfunction. I have enormous number of patients with thyroid dysfunction in my practice, and I believe many other less diabetes, but you see often autoimmune and endocrinological disease go together, unfortunately. And then lastly, increased rate of endometriosis. What really was fascinating for me, that endometriosis, an inflammatory condition, also occur when you have an imbalance of Th1 over Th2. Remember, Th1 are pro-inflammatory, mainly, if I simplify it as much as possible. The immune system is not simple. And Th2 is anti-inflammatory, but when there is imbalance, you have more chance and more higher rates of endometriosis. And that's what happened in multiple sclerosis. So when you have autoimmune disease that have a similar mechanism of action, mechanism of autoimmunity, you have higher rate of endometriosis, and that can affect your rate of fertility and the use of ART. Having said that, when you actually go for the fertility treatments, definitely sometimes women unfortunately go through some unsuccessful cycle, and that's delay the time to become pregnant. That time, most of the women with MS are off DMT. Some clinician will leave them on DMT, but there is a risk for relapses, either the stress, the trauma, the unsuccessful trial, the medication you're going into. And now it's important to speak about those medications that we use. Remember, I asked a question about IVF medication. So there are two types of medication. The main goal for giving medication to women when they go through IVF, regardless if they have MS or not, you want to block natural ovulation. You want to take this out of the equation because the ovulation and everything is being done elsewhere, correct? Outside in a dish, and that it's implanted. So I will give you a very quick, simplified biology, physiology 101. Really, if you think about the feedback that goes around, and it's almost for every hormonal function. So here, if we talk about ovarian function and pregnancy and menstruation, really, the whole menstrual cycle. So you think everything starts at the brain, of course. So the hypothalamus release a gonadotropic releasing hormone, that's the GnRH, gives stimulation to the pituitary to release the LH and FSH, luteinizing hormone and follicle stimulating hormone. Those really stimulate the ovary to release estrogen and progesterone. And if there is success and pregnancy happen, those estrogen and progesterone become up. If not, it goes back, and you can see the loop goes back with a negative stimuli, negative stimulation throughout the pituitary, and the cycle start again within our menstrual cycle. So the two medication, there are two of them, ones that are antagonists, so that's the GnRH, gonadotropic releasing hormone antagonist. What that does, it's actually stop right there, block the receptor of GnRH, so after you see the bubble of the hypothalamus, so right there it blocks, so nothing happened below below that. So immediately there is a reduction in all the hormone below, the FSH, the LH, and the estrogen and progesterone. So ovulation is almost stopped immediately. The other type of medication is those agonists. And the agonists, because they modulate the function of the pituitary gland, initially there is an increase in LH and FSH, and eventually through the feedback loop, because you have too much of estrogen and progesterone, it comes back and negated and you have less. Because of that imbalance with the agonists, it goes up and then it goes down. It almost confuses the immune system. So there was noted to be increased risk for relapses if you prescribe the gonadotropic agonist, releasing agonist, the GnRH agonists. If you can see a 7-fold increase risk for relapses after receiving treatment with the GnRH agonists. So important to discuss this with OBGYN, educate women about which medications is more appropriate to use once you have multiple sclerosis. So of course the antagonists are more favorable. So as I mentioned, there is no determinantal effect of MS on pregnancy. The incidence overall of miscarriages, stillbirth, congenital abnormality, prematurity, and complications are not increased in women with MS. So important to look at that. And really, there is no reason. Most women ask, do I need to go for high-risk OBGYN? I think they believe, oh, I have MS and it's a major chronic illness. And I always answer there is no need for it unless you had a history of miscarriages or you have multiple births or twin, or there is some concern regarding the health of a woman, but it's not a sure thing to do. Other issues that probably will be talked in by other lecturers, I will just go through them quickly, but just to mention that definitely other factors may affect women with pregnancy. Bladder issue, bowel may be worse during pregnancy, imbalance issues. So important about fatigue. The only thing that I felt during my pregnancy was the fatigue, and I pretty much lived in the bathroom. So imagine on top of it, you have MS. So it's just to think about all that and consider it in the discussion and the education. Is there a contraindication to pregnancy and MS? And I think that's sometimes a difficult topic, but you have to really discuss your concern with patients and their team and their partners always, because if they have a high disability level, high EDSS, it might be not favorable, or someone has a high activity at this point, maybe perhaps to postpone it a bit, treat the disease, and then I think our role is really in that discussion. And you have to be truthful and honest, as Mary Jean mentioned. So really important to discuss all the emotional, the social, even financial, religious. It comes up in a lot of this discussion. So women do actually better during pregnancy. We always laugh and say maybe women should always stay pregnant and just keep having babies. However, so why women with MS are doing well during pregnancy? It's almost a natural immunosuppressant. Really, the presence of the fetus, again, half of it, remember, it's antigens from a different person, from a partner that you've never met before, and hopefully you met him before you became pregnant. So, but you know, we always joke and say, you really don't reject the baby when it's intrauterus or as a baby, but you reject them when they become teenagers, you know? It's like, we always joke about it. Thank God I'm beyond that phase. My colleagues, though, have a few years for those teenagers. So what really happened in more details? When you become pregnant, all of us, our immune system go through that shift. Instead of heavily Th1 function over Th2, it's actually reversed. So you have more of a Th2, more of an anti-inflammatory effect. You have less inflammation, less relapse rate. It does not disappear completely. Some women may have relapses during pregnancy. However, most women do very well. And because there is downregulations of T helper 17, which also are pro-inflammatory natural killer cells, and upregulation of those T regulatory cells that really control everything. So really it's a favorable time, and there is effect of the fetus as well, exchange with the mother. So definitely a positive and protective effect most of the time during pregnancy. Although there is a high level of hormones during pregnancy, definitely it's very high, and we know it has some effect on the immune system. Although I think all of us, I shouldn't say all, many of us are postmenopausal. So I think beyond that 50, young 50 age. So hormone really change who we are, affect our self-emotion, as you know, all the time. So where is the evidence about the effects of hormone? They are so important, although definitely women have that imbalance up and down, sometimes can affect us physically and emotionally. So hormones, though, affect the immune system. They shift cytokines. They decrease those adhesion molecules that you saw with natalizumab, for example. The MMP, the matrix metalloproteinase, those two are very critical in the integrity of the blood-brain barrier. So if you have an effect on that blood-brain, you can, and the integrity of the BBB, then a cell can enter the central nervous system and cause that inflammation. So, and it decreases antigen presentation, although we don't know what the antigen that's responsible for MS, but it does decrease that presentation and boost number. Remember, I just talked about regulatory cells. So you really have decrease overall in the inflammation. So many clinicians had that idea. I think it's a brilliant idea to mimic the amount, the level of hormones during that occur naturally during pregnancy, to replicate it in women that are not pregnant. So we'll give you the idea that you're almost pregnant just with the hormone and try it. And there was a pilot study. They monitor women 6 months before, then they give them estriol for 6 months, then they monitor them after. This is the study. It's, you can see, 8 milligram a day. For a period, so it was just 6 months, 6 months before, just monitor and after. And they were very optimistic and hopeful, and they were excited. They were excited because there was a decrease in number and new lesions on MRI, so decrease enhancing lesion, active lesion. So ultimately reduction in new lesion formation, and decrease disease activity only in relapsing and remaining MS, not in secondary progressive. But then they have to do the large study. So here they go. They go to the preventative postpartum relapses in MS. It was a large study, mainly was done in Italy and France. As you can see, people got, it was a good study design. It was randomized, double-blind control study, so really good design. As you can see, each woman received progestin 10 milligram daily and estriol 100 microgram patch, and you had a placebo arm. But you can see it was a bit disappointing. The postpartum annualized relapse rate was 0.97 in the placebo and 0.9 in the treatment arm, and the p-value was 0.79. So not statistically significant. It didn't show that there was a difference between those that took the hormone and those that took dummy pills. So that's why it's so important to do large trial. I believe, if you ask me, I think women do so well in pregnancy, probably combination of factor, but I think mainly that the immune system changes throughout this period, and we don't really, again, reject the fetus, allow the growth, and really, probably though, that the hormone help and support that because they have an effect on the immune system. The other part of pregnancy that not only it affects the relapse rate, which I'll share with you in a second, the data from Conte Favreau, It also affects the progression of the illness and the diagnosis of MS. So here, a few studies, it's a bit crowded. You have the citation. So you can see that there is a decreased risk for a diagnosis of MS if you were pregnant at some point. And also, the progression of your illness is delayed and less in those women that became pregnant after a diagnosis of multiple sclerosis. So pregnancy does something. As you can see, having a child after diagnosis of MS increased the time to use of a wheelchair and time to EDSS-6. So that really walking with assistant, walking slow, and the use of wheelchairs. So that's a profound thing, that you can delay disability, progression of disability, just by becoming pregnant. A novel idea. Not so easy to become pregnant, correct? Anyhow, the Australian study showed the same thing. The risk of a first demyelinating event was inversely related to number of children and was lower in risk in those women that had 4 pregnancy or more. So again, the parity is important here, showing the more time you're pregnant, perhaps your progression will be less, and the diagnosis really, you can may be able to reduce the risk of having a first demyelinating event if you have the susceptibility for it. So we do see that. How come it happened? There is some thoughts about the exchange between fetus and mother via the placenta for hematopoietic stem cells. So hopefully we'll know more in the future. There's lots of research in stem cells, so hopefully some breakthrough will come in the future. So as you see, pregnancy affect the relapse rate, affect the progression of the illness, affect the diagnosis. When you think back how clinicians in the past told women with MS, you cannot get pregnant, it's forbidden for you to get pregnant. And it is interesting how much we learn in the last few decades. So as you already probably know, the pregnancy time is protective, and here is the data from Confavro and Vucosix. You have the citation. These actually, it should say 254 women of a total of 269 pregnancy, and you can see that during pregnancy, before, let me start, the year before pregnancy, the relapse rate was 0.7. It's plus minus. This is the standard deviation of the group, the homogeneity or heterogeneity of the groups. And as you can see, during the pregnancy, it went down to 0.2 rate of relapse rate. And postpartum, it really increased to 1.2. So I think we know after this study was done in the late 19s, and some of the articles were published in the 2000s, but you definitely see a positive effect on reduction in relapse rate throughout the pregnancy. There are treatments that may be given during pregnancy. Steroids may be given throughout pregnancy with caution. Very few clinicians leave patients on glatiramer acetate during pregnancy. However, the main thought is not to have any women on DMTs, disease-modifying therapies for MS during. Let me talk a few minutes about steroids. IV steroids are given when someone have a major acute relapses. You can see if you give steroids IV in the first or the second trimester, it can cause some intrauterine growth retardation of the baby, premature rupture of the amniotic sac, and also worsening of gestational diabetes, hypertension because of the steroids. I have one woman that I actually gave steroids in the second trimester. She had a major attack. She hardly could walk, have a relapse in remitting MS. I discussed it with her OBGYN. Everything went well. She has a second boy and very successful. But you always have that concern. What are we doing with the IV steroids? But I will never provide them with the steroids without discussion, as I mentioned, with OBGYN. So this is more in details, really, first trimester, because there is so much organogenesis throughout the first trimester. You really want to avoid, if possible. Steroids may be given in the second trimester with caution. In the third trimester, you probably can provide it more safely because it does help mature the lungs of the fetus, and usually it has a positive effect. But again, only if necessary. I provided, so let's talk about the DMT. As I said, only glatiramer acetates that I know of has been given to pregnant women if they have high-risk disease. So if I put in the categories. These are the old categories, A, B, C, D, and X, and you have it. It's the availability of animal study and in human. However, the new category, so I'm going to go through that quickly. The new guidelines for pregnancy, for medication during pregnancy is very important, and that's the route that clinicians should pay attention to. This was approved by the FDA in 2015, and by now, most companies have to really abide by, and I think one of the positive thing from this was that every pharmaceutical company must have a pregnancy registry. In the past, it was if you want it, you did it. Now it's a mandatory thing. Every company should have it, not only related to MS medication, all medication. And I think that's very positive. We need to monitor women that are pregnant. Someone mentioned earlier that you have a lot of unplanned pregnancy. So you want to monitor them if it happens on their medication. It's their obligation to provide us with data, so that's important. I think also one other positive change based on these new guidelines, that you have details about pregnancy, about lactation, about reproduction of male and female, and so you get a detailed information. Sorry, I went too quickly. I'll go through this quickly. You have the data in your slide, but I think just to show you the difference here, when you say C and B, it's all same. There are so many medications that are category C, and you'll see, I'll show you the difference between each medication, and they both category C. So you see the advantage of the new guidelines that give you much more information. So information. Embryo lethality means embryo toxicity with fatal outcome for the fetus. So you can see interferon has positive embryo toxicity, no teratogenicity, and no evidence of spontaneous abortion or birth defects in exposed human, those human that coincidentally became pregnant. Glatiramer acetates, we know the old categories, so you can see no embryo lethality, no teratogenic risk, and no evidence for spontaneous abortion or birth defects. So those about the injection, I put them in lumps, injection, oral, and IV. So these are the oral medication, as you recall here in earlier, fingolimod, dimethyl fumarate, and teriflunomide. So you can see here, for example, I'll give you an example. Fingolimod and teriflunomide and dimethyl fumarate, Tecfidera, the other name, are both category C. But when you go into the detail, you can see they both have positive embryo lethality. However, fingolimod has some positive teratogenic risk, and dimethyl fumarate does not. And there is some reports of birth defect in exposed human related to fingolimod, not so in dimethyl fumarate. So you can see the advantage of the new guidelines. It gives you more details. In the past, we learned all of them are category C. We treat them the same, but it's really not the same. And teriflunomide, you heard enough about teriflunomide. Leflunomide had the parent drug, leflunomide, which is approved for RA, as you heard, had some teratogenic side effects, but however, teriflunomide have both, but no evidence for spontaneous abortion, and you know about the category. So I think the new category, the new definition, the new identifier for medications throughout pregnancy have more details into it, and you can see about the data about natalizumab and alemtuzumab. Also, all these three, and ocrelizumab, all the three are category C. But you can see that there are some differences. Read into it, educate your patient, and discuss it with them. That's the data we have. So I think that's really important once you empower yourself and you know the difference between all these three medications. you can educate and tell people. The issue is that there is no really guideline and consensus about when to stop this medication and wash out and all that. And I think every clinician pretty much does based on their experience, based on her knowledge, evidence that's available out there, although it's very scarce. This is some data that I looked in labor and delivery. Some of it is not new. This is from 2005. I'll share with you new. So this showed to you, this is in Norwegian. I'll share with you that. And there was some other study, which, you know, in Europe, there is a very good database as compared to the United States. We don't have a good database here, but they looked at women with MS, and you can see versus control that the rate of C-section is much higher in patients, in women with MS. Same here. I think the community in MS, experts, were a bit concerned about that when they learned that perhaps babies of women with MS have smaller baby for their gestational age, and you can see the difference. However, a more newer study that was done was published around 2009 or so. 2011 actually was published, but the study was done up to 2009, and you can see it was done in British Columbia, very large study, 1,600 patients without MS and 269 looking at women that are pregnant and their baby weights, and it did not show any differences in the C-section rate or the weight of the baby compared between control and women with MS. So I think the community decided, and the National MS Society came with a claim and a statement that we're not concerned at this point. There's not a lot of data about the weight of babies and differences in the rates of C-section and the outcomes of fetus to women with MS. So there was nothing, we didn't adopt it, and there was no change in our clinical practice. So let's talk a bit about postpartum and MS. Definitely, we know that there is increased rate of relapses postpartum. You learn the pregnancy periods is safer, especially the third trimester, there is a reduction. However, postpartum, you can see it goes to the 1.2 annually rate, and 20 to 40% of women will experience a relapse during the first 3 months postpartum. However, they had a very small percentage of women that had relapses in their study. That's Vukovic and Confavreau. So it's hard to tell, only 28%. However, there was a recent study that, and I like Philip's study because he looked at monthly rate, because when you look postpartum, you're really divided by months and weeks, so it gives you much more, I think, accuracy perhaps. So you can see Philip's look at prior to pregnancy, the monthly rate of relapses in, of course, women with MS range between 1.36 to 1.67%. During pregnancy, slightly, you can see definitely low, 0.87 to 1%. And then look at the breakdown that he did, and I think it's really, really phenomenal. Looking at 6 to 12 weeks, 1.95, 3 to 6 months, 2. So that's pretty much is the same percentages you see. And I think what was interesting, because I don't think that Confavreau waited and looked at really beyond those 3 months. They went a year after postpartum and showing that you go down. So you come back perhaps to your baseline when you removed far away from the pregnancy, the postpartum periods, I mean. So I think interesting data. Postpartum IVIG, again, off-label use. I think one of the first people that used it is Dr. Pat Coyle in Stony Brook. Really, she thought that it has some effect, and some people in Israel as well, Dr. Akiron in Tel Aviv. So they showed some effect. However, more recent study, you have some conflicting results. So I think when you have conflicting results and you see no significant effect on reduction of relapse between those that received the IVIG and did not, and IVIG is not a walk in the park. It's a hefty medication given IV. There are lots of side effects you need to monitor. So I think, again, further studies are needed to really know if it's effective. So, so let's move on and finish with breastfeeding. We talk about postpartum. So is breastfeeding protective when you breastfeed exclusively? And there is a lot of interpretation what it means exclusive breastfeeding. So again, it's really important to know that it's basically when you don't supplement, at least in the first 2 months postpartum. So you breastfeed exclusively at least for 2 months. So there are a few studies. One was a meta-analysis. Remember meta-analysis? They take all the studies in the topic and do another statistical analysis. So this was only 12 studies. There are not that many studies to begin with, but 12 study, as you can see, combined number of patients, 869. Who breastfed, all with MS, and 689 that did not breastfeed. Again, all the cohort was patients with multiple sclerosis, women. And you can see a 47% decrease in postpartum annualized relapse rate. However, there are lots of limitations in this meta-analysis because most of the studies, the groups were not similar, so that's the heterogeneity. The amount of breastfeeding was different, some breast less than 2 months beyond, so it's not was a comprehensive number, and some people have different activity pre the pregnancy, and some of them use the DMT. So again, lots of limitations of this meta-analysis. Well-known study of Langer at the West Coast, Dr. Langer Gould, and you can see small study, but sometimes it's very difficult to do large study. 32 pregnant women with MS and 29 match age pregnant control. And I'm really looking at those women that did not breastfeed or began regular supplemented feedings within 2 months had an 87% chance of having a relapse. And those that actually breastfed at least for 2 months exclusively has 36% of experience in a relapse. So major differences. So it does suggest that exclusive breastfeeding reduced the risk of postpartum relapses. I think we need to do more study, and I think it's an individual decision. When I see patients, it's really depend on their disease activity and what they feel like, if they're really, really very committed to breastfeeding. Sometimes there are some women that are okay with supplements. Some women really feel so strongly about this. It has to be a discussion. Almost with every autoimmune disease. And think about the wealth of the mother as well and the health of the mother. I think sometimes clinicians focus on the baby health and maybe OBGYN think about the baby and how wonderful is breastfeeding. It's wonderful, yes, absolutely, but if it's risking the health of the mother, we need to think about that and consider the alternative. In summary, many factors that affect pregnancy, postpartum, the whole period, and we talked about a few of them, definitely sleep, fatigue, low endurance, emotional, psych issues. Think about postpartum depression in your population in MS patients, so it's all there. Some clinical implication to summarize, so definitely pregnancy is not contraindication indicated for most women with MS, depend on the disease activity. Not usually recommended to be on any DMT when you're pregnant. There's not clear understanding about the effect of breastfeeding, but it has a favorable effect, as I mentioned. So it should be considered with women in the discussion. Women, most of the time, that's my field, women that had relapses during the pregnancy, I most of the time try to convince them not to go for breastfeeding and really go immediately on the DMT because the risk is high. But I think every clinician has their threshold and what they feel. But I think that has to be discussed. If you have activity during pregnancy, that usually is a protective period, that means your disease is active, and we need to think about this and be proactive. You need to have a thorough discussion with the whole world team. This second class mainly focus on education and education. My colleague mentioned education is essential, and of course they need to take acts and be really proactive. But remember, it's really an individual decision that has to be discussed with women and their partner and the whole team. And I think this is it. Thank you so much. Thank you very much.